A new dawn, a new horizon of healthcare delivery and patient safety. We have a goal, a noble drive.
Hand in hand, step by step, we will thrive.
To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion. Standing right by your side. Joining hands for building a vision, shaping a culture for patient safety.
Setting up standards with best foot forward. Won't ever leave no stone unturned.
We wear our pride on our sleeves, work with passion like a breeze, training people, enhancing their skills, spreading the message of quality healthcare for safer patient care, a better nation.
We have a goal,
We have a goal,
a noble drive.
noble drive. Hand in hand, step by step, we will thrive. To march ahead together for a bright and shiny future with patient safety and quality healthcare. We are CAHO, your healthcare companion, standing right by your side.
Oh, welcome everybody. Good morning, good afternoon, good evening, depending upon which part of the world you are joining us from. I'm Dr. Vijay Agarwal, President CAHO, welcoming you to this very important 63rd webinar of CAHO and ISQua. Ladies and gentlemen, these webinars have become like a collector's items. All those people who are joining us late, you are welcome to go to the CAHO website and go through the previous webinars. There, each one of them is a gem to kind of go through. So once again, for the new episode, I hand it over to Dr. Lalu Joseph to introduce the speaker and the moderator for the day. Over to you, Lalu.
Thank you so much. Very good evening and welcome you all to the CAHO-ISQua webinar series. It's my privilege to introduce Dr. Jesu Krupa. He is a cardiologist, the Associate Professor of Cardiology from the Christian Medical College, Vellore. He's also the Deputy Director Quality and a great musician. He must be wondering as to what the CAHO anthem was. Dr. Jesu, you're welcome to contribute to the CAHO anthem. I think all of you must listen to him sing. He is involved in echo training of DM and cardiac tech students, supervising several research projects too. A very passionate teacher, and he's editor-in-chief of JIAE and CVI journals. He's NBE certified in adult and comprehensive electrocardiography. An excellent human being, and it's a pleasure inviting you to moderate this session, Dr. Jesu, and I'll hand over to you to give a preview of this webinar that we are hosting today, and also to introduce Dr. Rahul and to take it forward. Thank you so much for accepting our invitation.
Thank you, ma'am. And thank you, sir. Thank you, Dr. Vijay, for the warm invitation and the privilege to kind of moderate this session. I learn so much from Dr. Lalu every day, and being a newbie to quality in our own hospital. So this is a very interesting topic, and I think changes in the world, namely war, and few years ago we had COVID. No one really knows how things change overnight and what direction healthcare takes. Last year there wasn't much of this AI buzz going around, but now almost everybody from a child, it's the buzz in the air. Everybody is talking about digital transformation and AI. So in this particular context of change, how do we kind of future-proof healthcare? What are the systems that are required? What changes do leaderships need to make? What is the workforce that needs to kind of undergo change, etc.? So to hear about this today, we have nobody better than Dr. Rahul Deshmukh. He's a distinguished clinical leader and healthcare quality expert with over 25 years of experience spanning anesthesiology, clinical governance, and strategic hospital leadership. He currently serves as Director Quality at Zulekha Health Group, Dubai, where he holds quality governance and patient safety across the Zulekha hospitals. He concurrently holds the role of international physician consultant at the JCI, conducting accreditation assessments at hospitals across the globe. He's had numerous achievements in advancing healthcare quality in the UAE, and he was the main driving force behind UAE's first DNV recognized orthopedic hospital of excellence in 2022. He played an important role in securing the first IHI age-friendly hospital in the Middle East and North Africa region. That was in 2021. And he successfully led two JCI accreditations in 2022 and 2025 8th edition, and was instrumental in achieving HIMSS Stage 6 Digital Health certification. He is a committed researcher, academician, developed about 17 validated PREMs in collaboration with CAHO, results of which were published in the BMJ Open Quality. He's also the principal investigator for CAHO's initiative on PROMS and is the program director for the Fellowship in Clinical Governance, which is actually a joint program with the Indian Institute of Public Health at Gandhinagar. His academic qualifications, apart from being an anesthesiologist, include an MBA in healthcare management from Edinburgh University in the UK. And also, he has certifications in Healthcare Quality Certification Commission USA and FISQua, that is the Fellowship in International Society for Quality in Healthcare. He's a prolific researcher, multiple awards, and has presented numerous papers, and is a very important speaker in various fora. With deep expertise in JCI and DNV accreditations, electronic health records implementation, quality improvement methodologies, and patient-centered care models, Dr. Deshmukh is a sought-after voice on healthcare quality in the Middle East and beyond. So it's my privilege to welcome you, sir, to deliver and to share with us your talk on future-proofing healthcare, the need for agile clinical leadership.
You are muted, Rahul. Unmute yourself, please.
Thank you, sir. Thank you so much, Dr. Jesu, for those kind words and that kind introduction. So when I took up this topic of future-proofing healthcare, hardly did I have an idea that we will be in the middle of a war, and we'll be really experiencing the kind of uncertainty that comes along with a war. Allow me to share my screen, please. Please let me know once the screen is visible.
The screen is visible.
Thank you. Thank you. So just as I was talking about the uncertainty, it is not only war that brings uncertainty, technological or industrial evolution or revolutions as well bring a lot of uncertainty. These are some shining examples of various industries and companies of various industries who were leading world leaders, somebody like BlackBerry or Nokia, or for that matter, even Yahoo and Kodak, all of them world leaders in their respective fields at certain point of time, did not evolve with time, and currently we all know what is their standing in the world market. The take-home message is innovation is essential for a sustained leadership. We need to innovate, we need to change. So let's start with first understanding what is your take on change in healthcare industry. May I request everyone to use your mobile phones to just scan the QR code and give your opinion on this. Whether to succeed in future, change in healthcare industry is important, but it is not mandatory. It is essential and unavoidable. It is optional and not essential. It is not mandatory that everyone has to change in healthcare industry. Or is it like good but not really important? I'll wait for a few seconds or for a minute or so. You just need to scan the QR code and choose the option that you think is right. That makes my job much easier. If 100% of the audience is thinking it is essential and unavoidable, that's much easier for me to talk then. It is important but not mandatory. Okay, we'll move on. For those who think we can survive without changing, let me bring you to the latest prediction by Elon Musk. This is the same guy who has developed Tesla and SpaceX. And as per him, by 2030, remember the timeline, 2030, that is just another 4 years. And he is claiming that robotic surgeons will surpass human performance. In fact, the actual statement is human surgeons will be extinct by 2030. This is an extremely bold statement, and most of us will not agree with the timeline. But the key message to be taken away here is technology is going to change the face of healthcare industry. And that's why it is really important that we keep up with those changes. And that's why the topic of the day is future-proofing care, agile clinical leadership. Obviously, there are too many facets to it, right from things like supply chain to human resource management. What we will be restricting ourselves is the change management in healthcare as such. This is the roadmap of my presentation. Firstly, we will be establishing why do we need change. Then we shall look at why does the change fail? What are the various models? How do we ensure successful change? How do we monitor our performance? And then we shall conclude with take-home message. The learning objectives for today's presentation are first and foremost to understand the importance of change management in healthcare. Then we shall be evaluating various change models, and then we will look at real-world applications of various change models that we learned about. As we were rightly saying in the beginning, change is must, but why? Why do we need to change? First and foremost, as the prediction by Elon Musk, rapidly changing technology, be it robotic surgeons to robotic pharmacy to AI, technology changing the face. So it's really important that we keep up pace with that changing technology. Aging population, that's another thing, particularly in the Western world. Aging population with plenty of comorbidities is presenting newer challenges. Japan, the kind of technical or clinical issues that Japanese doctors are facing, Japanese healthcare workers are facing, are unique. And that's why it's important that we update ourselves to those practices. Global warming impact. Diseases like chikungunya or dengue were not heard of maybe about 30 years ago, but they are currently one of the top diagnoses across many hospitals. Social impact issues, regulatory changes. Many a times, now particularly with the accreditation agencies, it becomes mandatory for us to change our practices, be it NABH or be it JCI. It is now regulatory as well as the accreditation agencies which enforce change in healthcare. Shifting practice patterns, and of course, the use of evidence-based medicine. So as the evidence evolves, we also need to evolve our practice. But after understanding that change is important, what will happen if we don't change? First and foremost, there will be stagnation in business. And then, of course, that will eventually lead to a lot of other calamities, such as financial loss, missed improvements, moral decline. Your competitors are going ahead with better technology, better implementation of newer projects, while you are still stagnant at wherever you were. And that will lead to not only moral decline in your team, but higher turnover. Your doctors, your nurses will be dissatisfied and are more likely to leave for better organizations. Obviously, the customers, the patient dissatisfaction, and the competitive loss or losing market advantage is another important thing. And that's why it's really important to change the way we work. Again, this will be an interactive session. I would keep on asking for inputs from the audience as well. So again, if you can just scan the QR code and answer this question, what percent of change initiatives in healthcare succeed in your opinion? Around 18%, around 30%, around 48, that is around 1 in 2, around 75, that is about 3 in 4, and 100%. So whatever change initiatives are taken, all of them succeed as for 100% options. I'll wait for a few more seconds. So 50% of the audience think around 48% changes succeed, while 20% think that around 30% change initiatives succeed. And that's the actual right answer, that around 30%. So around 1 in 3 initiatives that were taken succeed and achieve the desirable result. So that's around 30%. So 70% change initiatives in healthcare fail to yield the derived result. And why does that happen? Why do change initiatives fail? There are a few common reasons. First and foremost is if the leadership is looking for quick fixes, prioritizing immediate results versus long-term results. That is one of the reasons why change initiatives fail. Ignoring underlying issues. This is probably the biggest problem that we face. We are looking at the superficial success or superficial or short-term success and really not thinking long-term. That is another major hurdle that one needs to cross. We need not seek for quick fixes and do not ignore underlying issues. But are these the only reasons why change initiatives fail? No. Communication breakdown is probably the single largest reason why change initiatives fail. And communication breakdown can be in various forms. It can be in the form of role ambiguity. People do not have clear roles and responsibilities where what is expected from them, they are not very well aware of it. Ignored concerns. Employees are trying to raise some issues, but the leadership continues to ignore those concerns by the employees. Irregular updates. People are not really aware of what's happening, how the change is going ahead. If that happens, again, project progress is not communicated and people lose interest or the engine loses steam and change initiatives fail. Similarly, messaging inconsistency. If the leadership is sending conflicting messages, that creates distrust among the employees, and that also can break down the communication. And of course, one-way flow never works. It always has to be two-way communication. Only then change initiatives will succeed. Another major factor that comes into picture is resistance to change. Whenever there is uncertainty, there is going to be resistance. And change is one of the biggest uncertainties that people face at their workplace. And therefore, that uncertainty can be in the form of increasing workload, whether this will increase. For example, if you're going for electronic medical records, the concern that the doctors and nurses will feel is, will it really increase my workload? Will it increase my documentation time? Will it take away time from clinical care? And will I be busy only in documenting? Heightened stress, employees feel overwhelmed and unsupported. Again, the importance of communication during change management. People need to be supported whenever we are launching any kind of change. Otherwise, there will be this feeling of overwhelmed or unsupported. Job insecurity, whether it will take away my job. Currently, we all hear this question, AI is going to take away my job, or is AI going to take away my job? That job insecurity, whenever you are introducing new technology, there will be people who will feel that their job might be insecure. And of course, there will be disrupted dynamics. And therefore, in those situations, there is collaboration and communication which suffers. This is the reason why there is always going to be some sort of resistance to change, be it a small change like modifying the practice of prescribing antibiotics, or a big change like rolling out of electronic medical record. We always anticipate some sort of resistance to that change. And that's probably the reason why only 30% of change initiatives succeed. But when you apply effective change management strategies in healthcare, that success rate jumps from 30% to 79%. That's why managing change will transform outcomes for patients, for staff, and for our organization. And that, ladies and gentlemen, is the importance of effective change management in healthcare. Now that we have understood that it is really essential to undergo change, we also looked at the consequences of not changing. We also looked at what are the possible hazards or what possible difficulties of implementing change. Now let's look at how do we manage change. Again, as I said, it is not going to be one-way communication. It is always going to be two-way communication between the two of us. So I would like you to tell me, have you been associated with any change management in recent times? And did you use any specific change management model as such? It could be change management in healthcare, particularly if I'm more interested in any projects or any change management that you conducted at your workplace, or you are part of change management project at your workplace. And did you use any specific change management model as such? If you are recently not part of any project, that's absolutely fine. But I'm sure every one of us has experienced some sort of change management. And if it is not in professional life, even personal life, it's also fine, no problem. Okay, yes, developing second line. Okay. Something as simple as shifting from Android to iPhone or iPhone to Android brings its own challenges. Here we are talking about systems that affect people's lives. So definitely there will be challenges. Yes, I have been involved in change management initiatives such as implementing new processes and introducing system upgrades. I followed ADKAR model. Yes, that's good. That's interesting. Yes, somebody else as well says ADKAR. EHR implementation using 5AS. Yeah, good, good. Interesting. Thank you. Let's look at different models of change. Various models have been proposed. We will be looking at each model, and we will also be critically analyzing that model. What are the advantages or disadvantages, or what are the strengths and weaknesses of each model? So first model is Lewin's model of change. It's a fairly simple model where it says that unfreeze the current situation, whatever is the current practice that you are using, unfreeze that, change it, and refreeze it. For example, you are using paper-based medical records, unfreeze that, change it to electronic medical record, and refreeze it to electronic medical record. Fairly straightforward, fairly simple. How does it actually stand the critical analysis? Critical analysis of Lewin's change model. Strength, it is very simple and easy to communicate. Unfreeze, shape whatever you want to establish, and refreeze. Very simple. It provides a clear structure for managing change. These are the strengths of Lewin's change model. The weaknesses are it is oversimplified and it does not really reflect the complex and continuous change in healthcare. It assumes that change is going to be linear and static. You just unfreeze and refreeze. It's not as simple as that. And therefore, it can be effective only for small scale, well-defined changes. It should be supplemented with models addressing complexity and continuous improvement. And continuous feedback and adaptations are essential for sustained success. Let's move on to the second model, that is Lippitt-Noster model of complex change. Here, this model is divided into three topics or three subgroups. One is the pre-project stage, second is implementation of the change, and third is post-project review. Again, sticking to the example of electronic medical records. So before the project is launched, we will conduct our pre-project evaluation. We will be going through various models of electronic medical record and then choose which model suits our hospital, our requirement. Then will be the implementation phase where we implement the change. We go live from paper-based record to electronic medical record. And then is the post-project review. After the implementation has been done, we then evaluate how successful is the change and how do we maintain that change. Remember the Lewin's model where we said refreeze. It's important that once we have changed the practice, we freeze that practice again so that everyone starts following that practice. That's what the Lippitt-Noster model also says. We have to divide change management into three subdivisions or three phases: pre-project phase, implementation phase, and post-project review. During all these three phases, change adoption happens via the vision of the leadership, the skills, motivation, resources available, and action plan. Let's look at it one by one. So as per this model, we need a combination of vision, skills, motivation, resources, and action plan to ensure a successful change. If you have skills, you have motivation, you have resources, as well as action plan, but you do not have the vision, we don't know where to go. We have all the kind of resources that are available. It's a highly motivated force. They have excellent skills and action plan and unlimited resources, but they do not have vision, what exactly needs to be done. That will lead to confusion. If you have the vision, as well as a motivated staff, resources and action plan, but you do not have the necessary skills, we do not really have an expert IT team that will guide us through that transition from paper-based records to electronic medical record, that will lead to a lot of anxiety. Nobody will be really sure what exactly to do and how do we go about it. That's the importance of skill. If we have the vision as well as skills, but the staff is not really motivated, there is a lot of resistance that you are facing when it comes to change management. Despite the resources that are available, as well as a very robust action plan, still there will be a lot of resistance and your change management might fail. You have the vision, you have a highly skilled staff which is really motivated, but you do not have the necessary resources, be it financial resources, be it manpower, to implement those changes. Despite having an action plan, it will be frustrating for the staffs because they do not have enough resources, be it, as I said, be it monetary resources or manpower. It is only few staffs who are then forced to implement that change, and that leads to frustration among the team members. If you have the vision, the skills, the motivation, and resources, but we do not have an action plan, that will lead to a false start, because we really don't know where to start and how do we take it forward, because we do not have an action plan. So despite all others, it will just be a false start and your change will not go through because we do not have a specific action plan. Usually when we launch any major projects, they come with an action plan, which could be 6 months to 1 year, and then it will be further divided into quarterly targets and whether we are meeting those targets. There is something called as a Gantt chart, which we will be referring to later on. That is part of the action plan, wherein there are deadlines that by, let's assume this is February now. So by March, we'll have to do these many things, or by April, this will be the target. So accordingly, for each quarter or each monthly targets will be there. And that's how action plans are prepared. Critical analysis of the Nostro model of change. We already looked at the Lewin's model, which was unfreeze and freeze. Now we are looking at the Nostro model. The strengths of Nostro model are it addresses complex change by highlighting the importance of vision, the skills, the incentives, the resources, and action plan. It's a useful diagnostic tool for identifying missing elements in change efforts. Whenever you are struggling in change, it's good to use this tool to identify where are we struggling, what is the problem. Is it lack of resources? Is it lack of action plan? Is it resistance to change? Is it lack of vision that is causing these hurdles for the change management? It encourages a holistic and systems thinking approach. The weaknesses of this model are it can oversimplify the dynamic and iterative nature of real-world change. It does not explicitly address stakeholder resistance or cultural barriers, though it talks about motivation, but it does not explicitly talk about resistance and cultural barriers. It lacks detailed guidance on sustaining change over time. What are the practical insights for this model? It is effective for diagnosing why change initiatives struggle and for planning interventions. So it's a very good diagnostic tool than a change management tool, because it will help you identify exactly what is the root cause of this problem that we are facing. That's why it's a very good effective diagnosis or diagnostic tool. It is best used along with other models such as Kotter's or Lewin's model for comprehensive change management, and one should regularly revisit and update each element to adopt evolving challenges. Moving on to probably the commonest or most popular model, that is Kotter's 8-step change model. These are 8 steps which will guide us through the entire change. Again, I'll be sticking to the example of transition from paper-based record to electronic medical record. Let's see how it goes. First and foremost is to create urgency, a clear, powerful narrative that captures the need for change. So first thing that we need to do is to establish the need for change. Why do we need to go from paper-based records to electronic medical record? What are the advantages of it? That needs to be communicated to the team. And so it can be something as simple as a regulatory requirement. The health sector or the Ministry of Health wants all medical records to be interconnected, and therefore it is important that we are on electronic medical record. So we need to create that urgency. Second is build coalition. It's really important to identify your change champions, a passionate, diverse group of people to carry the change through. This is a very important step where we identify people who will be working with us on this project. That is the build coalition. Third, develop vision, the ability to manage feelings to achieve goals. Then we should provide vision to the entire team that this is what we are planning to do and this is how it will be done. Communicate the vision, define and clearly communicate the change. As we said, one of the major factors for failure of change is communication breakdown. So it's really important that we communicate consistently, clearly, guiding people about their roles and responsibilities, what is expected from them. And again, it has to be two-way communication. It cannot be only one-way communication. So while we are delivering the vision to the ground force, it is really important to address the concerns that are being raised by the force on the ground. because that's where the real picture is coming from. And because effectively, it is the clinicians and nurses who are going to use that change. Whatever change you are implementing, the electronic medical record will be used mostly by the clinicians and nurses, and therefore it's really important that communication happens. Empower others to act, enable the business to define, plan, and carry out the change. It's really important that it can't be only the leadership, it has to be the entire team as such, which delivers that change. It can't be only driven through a boardroom, it has to be driven on the ground, and therefore it is really important that others are empowered to act on their own. Short-term wins. It's really, again, critical to promote short-term wins. Let's say Department of Cardiology completed their transition from paper-based records to electronic record. We need to celebrate it. Or the training program for nurses was completed on time. These are the short wins that we really need to celebrate. That keeps the motivation of the entire team together. Then consolidate. Keep the momentum going and consolidate gains. Those short wins, cardiology department finished, then we went to pulmonology, then we went to oncology. So keep that momentum going, and that's how we consolidate. The training programs for those people need to be completed on time, and that's how we consolidate. And then last is anchored change. Integrate that change into culture, system, and process and make it stick. So this is the Kotter's 8-step model, where we first create urgency of the need of the change. Then we build coalition, develop vision, communicate the vision, empower others to act, celebrate short-term wins, consolidate, and anchor change. Critical analysis of Kotter's 8-step change model. First and foremost, the strengths. It addresses the complex change by highlighting the vision, the skills, incentives, resources, and the action plan. It's a useful diagnostic tool, as well as it encourages momentum and sustainability to short-term wins and anchoring new approaches. Weaknesses. It can be perceived as too linear for complex and adaptive changes in healthcare, may not fully address resistance or cultural barriers at each stage. Even if it talks about resistance, but at each stage, we might encounter a different kind of resistance or cultural barrier, and the Kotter's model does not address it at each stage as such. It really requires strong leadership and resources, which may not be available at all times. Practical insights. It's effective for large-scale structured change initiatives. It is best used in combination with other models for continuous improvement and adaptability. And it is really important that we regularly revisit and update each element to adapt to evolving challenges. After that, let's move on to the next model. So we have so far looked at 3 models. One was Lewin's model, then second was the Kotter's model and Noster model. Now we are looking at the 4th model of change, that is Rogers' theory of diffusion of innovation. What it says is first and foremost is knowledge, where we educate and communicate with the staff. So spread knowledge. Second is persuasion, engaging change champions. Just like Kotter's model, where we identified the people or the core team which will drive the change, it's important to identify change champions. And we should have change champions across departments. In each department, we should have 1 or 2 champions who will be driving that change. Decision, the staff needs to decide acceptance or rejection. Whether whatever change we are proposing, it is the staff which decides whether to accept or reject that change. Implementation, putting new process in practice, and confirmation, staff continue to utilize the new process. Whenever any change is implemented, it goes through these different groups or subgroups of people, and that's how diffusion of innovation happens. First and foremost group is the techies, who are also called as innovators. They are about 10% of the total team. These people are very willing to take risks and want to be the first to try innovation. These are the people who would like to try their hands at the electronic medical record, or they would like to try the robotic surgery, or they would like to try laparoscopic surgery, particularly when we were shifting from open surgery to laparoscopic surgery. These are the innovators who will lead that change. Typically, these are about 10% innovators. Next category is visionaries, which are about 15%. They are also called as early adopters. These are the people who already are aware of the need to change and are very comfortable adopting new ideas. Though they are later than innovators, but they are still quite early. That's why they are called as early adopters. And they are aware of the change. They very well appreciate that change is going to happen, and therefore they are comfortable adopting to those new ideas. These form about 15%. So 25% is gone. Next are the early majority. These are pragmatists, and these people adopt new ideas after seeing the evidence that innovation actually work. That's why the work pragmatic. They are the ones who are judging. They are the ones who are still waiting for change benefit of adoption of that innovation, and then they will adopt it. Once this is the majority of the people, by the way, they are 50% of your total team. So once the early majority, the early adopters and innovators adopt your change, it is about 75%. 3 in 4 people have already adopted that change, and that diffusion of the innovation is almost successful. After that come the late majority. These people are conservatives, and they usually they are second to last segment of the population to adopt innovative technology, and it diffuses through a society. They will judge, they will take some time, but they will turn over at some point of time. They are about 15% of total population. And then the 10% will always be there. The skeptics, the ones who think this change, whatever be the change, is going to harm or is going to cause some problem, and they will be the last to adopt any new product or service. They represent change and may continue to rely, they resent change and may continue to rely on traditional products until they are no longer available. Again, going back to our example of shifting from paper-based records to electronic medical record, they will be the last ones to adopt to electronic medical record. It's despite shifting from paper to electronic, they might prefer writing things on paper first and then copying it in the electronic medical record. They will be the laggards, they will be the skeptics. That's perfectly fine. Whatever change you are managing, whatever change you are taking up, typically you will see these groups. Innovators who are really willing to take that innovation, they are willing to try out that new technology. Next group is the early adopters. These are the people who are aware of the change and are willing to try out or willing to accept that change. After looking at the advantages that the innovators and early adopters are getting, early majority are the ones that will take next. Then will be the late majority, and last will be the laggards. At this point, I would like to give you an example that we implemented in my previous organization. We shifted from paper-based to electronic medical records, and there was some resistance by some of our doctors that my eye-to-eye contact with the patient has gone. I'm busy typing on my screen, and the patient satisfaction will be very poor. At this point, we decided to introduce the voice-to-text or voice dictation system in our hospital. Obviously, there was some resistance to it. There were concerns raised about the accent, Dubai being the multilingual or metropolitan city, whether there will be issues with the pronunciation of the language, whether the system will be able to capture our understand our language or understand my pronunciation. There were certain resistance. Many of the doctors were not very comfortable using that system. That's when we introduced it in a limited number of doctors, with a limited number of doctors who were the early adopters and innovators. As the other doctors witnessed the doctors who were using the voice to text dictation or voice dictation system, slowly people started demanding it. Many of the doctors then started saying that we also need this system. This is much better than typing on the screen, and that improves the contact time with the patient, and that really improves patient satisfaction. We ourselves conducted some study based on it. We got some patient feedback. And then when we shared the data with doctors, early as well as late majority of them approved it, and they also started using it. And of course, there were still a few, may not be even 10% actually. They were the laggards who joined in late. As everyone else started using this system, we had stopped the transcription system, and eventually all doctors moved from paper-based system to the voice dictation and electronic medical record. Critical analysis of Rogers' theory of diffusion of innovation. Strengths, it addresses complex change by highlighting the vision, skills, incentives, role of innovators, early adopters, and change champions. It is useful for understanding adoption patterns and tailoring communication strategies. You will need different communication for innovators as compared to laggards. Innovators will be the ones who will need minimal communication with them, while laggards or skeptics will require a lot of communication and persuasion to adopt that change. So it's important to understand that communication strategies. It encourages stakeholder engagement and education to facilitate change. What are the weaknesses of this? It may oversimplify adoption or adoption dynamics in complex healthcare environments. It does not fully address resistance, cultural barriers, and organizational inertia. It lacks detailed guidance on sustaining innovation and initial adoption. Practical insights for using the Rogers theory. It is effective for planning and monitoring of the rollout of new processes. It is best used alongside other models for comprehensive change management, and it is important that we regularly revisit and update each element to adapt to evolving changes. Plan, do, check, act cycle. Though this is not a change management or change model as such, or change management model as such, but this is probably the model that most of us will be using on a day-to-day basis. This may not be really effective in long major projects like EMR adoption. You cannot plan, do, check, and then act for EMR adoption. But when it comes to smaller changes, it is really important. For example, I want to reduce pharmacy waiting time, or I want to reduce the waiting time outside the doctor's clinics, or I want to change the antibiotic prescription patterns of doctors. This is the time when we don't really need the quarters model or the other 8-step model and things like that. It does not need a long-term action plan of 1 year. If we are looking at reducing something as simple as pharmacy waiting time, it can be this particular model, the plan, do, check, act cycle, which can really help in implementing those changes. Basically, I'm sure most of us are aware of this, but I'll just reiterate through. First and foremost is plan for improvement. What is it that we want to achieve? Let's set smart goals. If I'm planning to reduce my pharmacy waiting time from 15 minutes to 8 minutes, that's what is my goal. Therefore, we start with what exactly is to be planned, implement the plan. The plan is put into action on a small scale first to see whether it yields results. So we might establish a separate counter for patients who come with insurance or patients from the wards inpatient department. We might have a separate counter in the pharmacy, and that will reduce the waiting time for outpatient pharmacy. So we'll put it a small change, we'll implement that plan and see. That's where check or checking results come into picture. We did this for 15 days and we realized that, okay, establishing a separate counter for patients with insurance or patients coming from inpatient wards saves time for outpatient department. That's a fantastic result that we have achieved. And now we act on that finding. And that's when successful changes are adopted. When upon checking results, if it turned out that establishing a separate counter for insurance patients or inpatient department does not really cut down the waiting time for pharmacy, we need to look at some alternative. Then that plan is not going to work. We need to have some other alternative and then again do that cycle. That is the PDCA cycle or PDSA cycle that is routinely used when we are implementing small scale changes. It need not be for big scale changes, but this can very well be integrated into bigger scale changes, but typically used for small scale changes. We had one-way communication for quite some time. Now, based on the discussion that we had so far, we'll be having a small quiz. I think there are only 4 or 5 questions. Again, may I request everyone to scan the QR code and join the quiz. We're at 49. Once we reach 50, we shall start. Okay, 53, 54, 'All right, let's start. What is a key factor in successful change management in healthcare? Cost-cutting measures, stakeholder engagement, employee resistance, top-down communication. Key factor in successful change management in healthcare: cost-cutting measures, stakeholder engagement, employee resistance, top-down communication. I'll just wait for everyone's answer to be logged in. All right, in view of time, I think I'll have to move on. So it is top-down communication, stakeholder engagement, employee resistance, cost-cutting measures. The correct answer is stakeholder engagement. It can't be top-down, it has to be two-way communication. Next question. What is the primary goal of change management in healthcare? Ensure smooth transitions, increase patient satisfaction, reduce operational costs, improve staff morale. All right. 48% of us say increase patient satisfaction, 41% say ensure smooth transitions. The correct answer is ensure smooth transitions. Of course, increase patient satisfaction is also common, but it is more important that we ensure smooth transition because not every change will be associated with patient satisfaction. Which of the following is a common barrier to change in healthcare? Government regulations, technological advancements, staff resistance, patient feedback. If we can be quicker in logging our answers, it will save a lot of time for each one of us. So common barrier in change management or changes in healthcare: government regulations, technological advancements, staff resistance, patient feedback. Staff resistance. This was the easiest one, of course. Which model is commonly used in healthcare change management? Is it the Adkar model, Lynch change management model, McKinsey 7S model, Kotter's 8-step model? Various models are available across, like I have highlighted a few, but there are plenty of other models which are available as well. Kotter's 8-step is the most comprehensive of all of those. So that's the model that is usually used. So AC, that's the overall winner. 4 out of 4. Dr. Raksha is second, 4 out of 4 again. Dr. Prasad is 3 out of 4. Madhumita is 3 out of 4, and Dr. Riya is 3 out of 4. Hardest question was which model is used in healthcare management. Okay. Now, moving on. So change management in healthcare is something like this. It's almost like changing the wheels of a moving car. You can't shut down a clinic or a hospital for 6 months saying that we are undergoing change. It will have to be much quicker than that. And therefore, it's important that that change happens smoothly. I'll be giving some practical tips and tricks, and then we will be calling it a day. So first and foremost, before change, it's really important that we involve the stakeholders in identifying the problem. What exactly is it that we are trying to settle down? Setting proper goals and action planning. It's key, or communication is the key here, and therefore involving all relevant stakeholders in these key areas, that is identify the problem, set goals, and action planning. Pre-change, again, all relevant stakeholders must be involved by forming multidisciplinary team, diverse representation of all disciplines. It can't be only doctors and nurses. You need inputs from everyone else as well. And establish or identify change champions across all shifts. It's really important. It can't be just the head of departments that are involved who will be doing only the morning duty, and rest of the staff does not have idea about what is being done. Next, identify facilitators and barriers. It's again very important that we identify people who will drive this change as well as people who will be resisting this change. Initial education efforts on facilitators. Barriers as such are going to be hard, or they are going to be hurdles. So first, we know or register those quick wins by concentrating on the facilitators. Innovators and early adopters are to be identified and involved as well. The first 25%, 10% were the innovators and 15% were the early adopters. These are the people that need to be identified because they are the ones who will be driving that change. And that's when the early majority will adopt that change. That will be the 50% that will be joining, following the innovators and early adopters. Then when we talk of change implementation, it's really important that we have open communication, open two-way communication that will minimize the barriers. Reinforce facilitators by recognizing efforts and offering incentives. Again, celebrating short wins, identifying people who have really put in an effort, offering them incentives. It's one of the ways by which we can drive that change. Identify facilitators and barriers, again, during the change implementation. Some of them might turn into barriers and some of the barriers might turn into facilitators during the change implementation. Therefore, it is important that this force field analysis continues all through the change implementation. Who are my facilitators and who are my barriers? You need to keep a track of that. Again, during change implementation, ensure that the process implementation goes on as intended. There should not be loopholes, there should not be shortcuts that are implemented by the team. The common example is, even if you are shifting to the electronic medical record, make sure that the doctors and nurses are entering that data in the respective field. We cannot have a situation where there are 15 fields in operative report, but still doctors continue to write an operative report as only one note. Because when you will be trying to retrieve data from that EMR, it will give no data because it is not in respective fields. The entries are not in respective fields. For example, pre-operative diagnosis, post-operative diagnosis, specimen sent, blood loss, all these need to be in separate fields. If your surgeons are writing it in one note, you will not be able to retrieve any data, and that will be failure of your change implementation. So make sure that process is implemented as intended. Identify departmental change champions, consistent engagement through change process, fresh force field analysis to identify new barriers or new facilitators as well. And if there are any concerns that are raised by the team, it is really important to address those concerns at this moment. Whatever change you are doing, if we can address those concerns during the change implementation itself, that will help you drive that change for a longer time. Identify new knowledge gaps. It may happen that you started with certain vision, and during implementation, we identified that, oh, these are new problems or these are new knowledge gaps that have come across. We need to go back to the vendor to address those gaps. Maintain close communication with all stakeholders and address their concerns. Recognize staff efforts. Really important to drive that change, that we celebrate short wins and recognize staff efforts. Continue monitoring progress with milestones. This is what milestones of the Gantt chart looks like. Each Gantt chart will have these components. For example, the timelines, which shows hours, days, or weeks, or months and quarters. By end of 1 month, this is what should be done. By the end of 2 quarters, this is what should be done. Vertical red lines indicate the current date. As on today, this is where we stand. Those arrows show how tasks are dependent on one another. So here, as you can see, the orange task leads to the green task, and then the green task leads to the next task, which will eventually lead to that event. Then there are various milestones which are projected in that Gantt chart. There are various bar colors, and then various bars which show the full duration of that particular task. Post-implementation. It's really important that we seek feedback from the end users, whether there are any difficulties that they are facing, are there any new challenges that they are facing, are there any possible improvements that are likely that can be done. It's important we get that feedback. At this stage, we also hand over the control to the department leaders. We have been driving this change so far. Now is the time to offload that to the department leaders so that you get yourself ready for another challenge or another change. Continue to monitor adoption and proper implementation, and set KPIs to monitor the progress. How well each department is implementing that change. It is really important to monitor that progress by the way of key performance indicators. And how do we measure success of change management? With the help of key performance indicators, such as process efficiency to measure workflow gains, system usage to show tool adoption, quantitative and qualitative monitoring of the data, project timelines and budget performance. Did we meet those project timelines, and how were we as compared to what was budgeted for this? It's really important. If a project which was supposed to last for 6 months took 2 years for completion, or if we were to roll out something like 1 million dirhams or 1 million rupees for a project, but we ended up spending 4 million for the same project, it is not a successful change management. Your change management has failed somewhere. Effectively, customer satisfaction and staff satisfaction. These are the indicators which will determine whether your change management was successful or a failure. If despite introduction of the electronic medical record, your staff is unhappy with it, obviously there will be some resistance or some unhappiness about it. But what is the percentage of that staff, and how happy are your customers with that change management? That determines whether your change management endeavor was successful. Take home message, I think this is my last slide. 70% failure rate in the healthcare change initiatives warrant effective change management. And that's when, if you utilize effective change management, the success rate jumps from 30% to 79%. Clear, measurable objectives are to be defined and communicated. Communication is one key aspect of any change management, and it has to be two-way communication from the leaders to the ground force and vice versa. Engaging all stakeholders is critical. Sustained leadership engagement at every stage. It can't be that we started a project and then we gave up on that project. It cannot be done like that. It needs to be sustained throughout the change management. And comprehensive measurement systems, tracking adoption and financial gains are important to measure the success of that change management. These are my references. Thank you, ladies and gentlemen.
Thank you, Dr. Rahul, for that exhaustive and comprehensive talk. You've kind of made it very interactive with the Q&A and the audience interaction. It's a time for questions. Please send in your questions if you have any onto the chat box, and we can put it across. Yeah, Dr. Anna, you can unmute yourself and ask if you want to.
Good afternoon. Dr. Rahul, hi.
Hi,
So,
Dr. Anna.
lovely to hear you, lovely to see you, and lovely presentation. It's
Thank you.
very, it's a coincidence, but this was my PhD thesis topic. So I had a personal, interest agenda, and I think you just presented it even better than how I may have
Thank you.
presented it. But very, very nice. And as you rightly mentioned, and the example that you have taken of EMR adoption, it's the most in thing now, right? Like it's happening
Yes.
everywhere. And I think in many places, somehow the change is not well accepted. It goes wrong. And I think you have highlighted all those points, though you have mentioned many models. There could be, scope for, us coming up with better models, because some of them may not be adapting to healthcare, rightly mentioned by you as well. So the main thing being communication, the main thing being involving all stakeholders, the whole drive about early adopters and how you use them as examples for the late adopters, and those things are probably some of the strategies that have worked. So excellent topic, excellent inputs. I'm sure you have a world of experience in change management, especially with regard to EMR adoption, and you're talking from your experience. So thank you so much for that.
Thank you. Thank you.
Any
Yeah, it's a
questions?
complex thing. That's the thing. Change management is always going to be very complex. There are going to be n number of aspects to it. It's difficult to fit it in one presentation as such. As you were rightly saying, it's a topic for a dissertation for sure. And congratulations on your dissertation. Thank you.
And I
Yes,
think
Dr.
there would be a difference in different industries also, the
Yes.
geography, the kind of people, because
Yes.
our
Yeah.
healthcare industry is very complex, because you have people from different walks of life, different educational background, like everything is very
True.
different, right? Technical
True.
specialities,
Yeah.
etc.
And another major challenge, particularly when it comes to electronic medical records, is the senior clinicians may not be very tech savvy. And that brings
Absolutely.
a big challenge. That's
Absolutely.
probably the biggest challenge, because most of them will be your star doctors, so to say. And
You
when
can't
they
disappoint
address
them.
the change,
Yeah.
that brings a different set of challenges altogether.
Very true. Very true.
Yeah.
Dr. Babu?
Yeah, Dr. Rahul, that was a very excellent presentation. Happy to see you.
Thank you.
And of course, I was into another meeting, so I had the privilege of attending only the last 30 minutes or so, but it was very good presentation, very impressive.
Thank
And
you.
of course, I think you have answered that question, like everywhere the clinician happens to be the most resistant part to change. Other than that, during your, I mean, like your preparation of the slides and other things, or your research into it, do you find any kind of factor or some kind of characteristics or otherwise a particular segment or segment of population who are resistant to change, in the sense that, for example, there are, when we take healthcare system, there are paramedical people, then administrative staffs, and those kind of things. Of course, clinicians, we know that we are the most difficult nut to break. So is there any kind of, I mean, like psychologically speaking, is there any kind of characteristics of people or otherwise other kind of factors which has to be taken into consideration when we are looking into, as you know, that now world is looking into a different perspective of behavioral therapy and other things? Just I was asking.
Yeah, thank you. Not during the preparation for this particular topic as such, but when we rolled out our EMR, that time I was going through the electronic medical, data for satisfaction surveys of doctors, because we conducted at the end of the EMR adoption, we conducted our own surveys at the hospital. That time I came across something really interesting. It was a meta-analysis of various electronic medical records that are available. So various softwares. It need not be only Epic or TrackCare or Achille systems. Across the world, whatever electronic medical records are available, a meta-analysis was conducted for those electronic medical records. And you won't believe, but 64% of doctors were unhappy with that. So whatever electronic medical record was given to doctors, 2 out of 3 doctors said they are unhappy with it. So that's the biggest challenge, of course. That is one. Second is, of course, how tech savvy you are. That particularly when we are implementing any technological solutions, that becomes a second factor that comes into picture. People who are very good with technology, who are tech savvy, they adopt to that change much easier. People who are not that tech savvy, they are not really into, so as they call as tech natives and tech immigrants. So the younger generation who have been exposed to technology right from their early childhood, they are much easier to adopt to change as compared to people who have to adapt to a technological solution at a later stage. So probably these two are the components, or these two subgroups are the ones which turn out to be the most challenging ones.
Yeah, that answers my question. Thank you very much. But one important point is that like the early adapters and innovators, when we capture those 15 to 25% and try to
Yes.
advertise ourselves, then these kind of pragmatics comes into it. Then the snowballing
Yes.
effect happens. That's how I think so.
Yes,
You have
yes.
experienced the same thing.
Yes, yes. That intention, in fact, that was a strategy that was used by our IT director. He said that this voice to text, I want to keep it like it was like a limited time offer. So we literally asked the doctors who would like to taste it, and early adopters, obviously, few of them said, yeah, I'm willing to taste it. And once others saw the advantage of it, others saw the benefit of it, then people started demanding for it. And then we had to create separate license for it and all that kind of stuff. So yeah, it works. It definitely works. Yeah.
Thank you.
Thank you.
There are a couple of questions in the chat which you can
Sure.
also look at. The first
Yeah.
one, when the management is quite busy and when the workload is more, how can we be effective change agents? And there's another one, is it appropriate to combine change management models in
When the
healthcare?
management is quite busy and when the workload is more, okay, how can we be effective change agents? Yeah, so again, it is about availability of resources. If you go to that slide where it was about having vision, having the plan, having the motivation, having the adequate resources, it's really important that, but it depends upon the level of change management that we are looking at. If it's a massive scale of change management, we definitely need adequate resources. Without resources, it is always going to be a challenge to drive that change successfully. So yeah, but again, what we need to do is to identify change champions. Who are the people who will drive that change? Obviously, it need not be only human resource as such, but who are the people who can drive that? So instead of recruiting new members or new team, if we can identify the right people and communicate with them, we can still drive that change. But it is going to be difficult. If you have limited resources, it is always going to be difficult. And I'm talking about human resource as such.
There's another one. Is it
Yeah.
appropriate to combine change management models in healthcare? If one doesn't work in a scenario after adoption, can we change the approach?
Yes, it is rather it is advisable to combine a few, because as the critical analysis of most models says, that it is, we do not have a comprehensive model which will suit the healthcare industry and still be successful. So we might have to something as simple as, let's say we started with the 8-step model, and then in those 8 steps also we can include the PDC or PDSA, the plan, do, check, act, can be incorporated in the same, or the Lewin's model where we unfreeze and refreeze. So it can be very well combined. It need not be only one model as such that needs to be implemented all through. We can very well combine different models and different strategies. Uh, if I was to summarize change management in one word, it will be man management. You need to identify the accurate or actual good resources and manage them. Similarly, you need to identify the barriers and manage them. Now, how you manage them is the skill of the manager or the leader. That's so whichever model you use, effectively all you need is proper man management. That will help us.
Thank you, Dr. Rahul. The question, I think there's a lot of appreciation and a lot of compliments, which I'm not going to read out. You can.
No, that's fine.
I think it is. You did fantastically well. You can probably just come back. We can just take half a minute to answer the last one because there are 2 of them, and if you can just answer this, the related to AI and how we can overcome the lack of knowledge. And someone's asked about implementing in the public healthcare organizations, including tertiary care, how challenging this. If you can just give a combined answer, that will be good in the interest of time.
Sure. Lack of knowledge regarding the use of AI is the major drawback to adopt it. Yes, again, that is going to be a challenge. AI in healthcare itself is it's a big, what can I say? It's a question mark. It is not that AI is going to solve all our problems. Rather, AI is going to bring a new set of problems, as it happens with any other technology. Paper-based records versus electronic medical record. We all think that electronic medical record is going to be a game changer. No, it is not. The kind of problems that happen when there is a cyber attack and when you do not have anything else, it creates a havoc. So very similarly, AI is not going to solve all our problems for sure. And therefore, when we adopt AI technology or when we adopt any technology for that matter, it's really important that we identify the right suitable technology for ourselves, for our product, or for our hospital. So that is most important thing. That's the biggest hurdle that we need to get over when we are choosing the right AI tool. So that's the first thing that. So even if you currently do not have any knowledge about AI, it is important that the leadership as well as the end users understand the product, evaluate the product, and make sure that it really suits the requirement of the hospital, and only then adopt that model or adopt that technology. Just for the sake of it, adopting any AI technology is not going to solve our problems. Rather, it is going to create more problems for us. So unless we have understood the entire product, no point in jumping for it. Just because others are jumping, we need not jump. How challenging will it be to implement in public healthcare organizations like tertiary care providers? Yes, public healthcare providers have their own, particularly back home in India, have their own set of challenges. The sheer volume of or number of patients that we treat is so humongous that we can't really be talking about technology or things like that. But at the same time, it is the same technology which will soothe or which will sort of streamline the processes, and that will help us in implementing better care or in providing better care to our patients. So yes, it is going to be challenging. The key again is man management. Identify who are the resources who are going to be helpful in this, And as people realize the importance of it, the adoption will happen. It is not that people don't like technology. It is the problem that people don't have time for it, considering the number of patients that are being treated in our public health sector.
Thank you, Dr. Rahul. That was fantastic. We could go on and on, but I'm sure in the interest of time, we'll have to bring this to a close. It's over to you, Dr.
Thank you.
Rahul.
Thank you. Thank you so much. My apologies. I missed the session, but I'm going to listen to the recording for sure. And thank you, Dr. Jesu, for moderating the session so well. And let me take this time to appreciate both of you for the efforts, for the work you put in, for engaging with our audience for the past 1.5 hours. Let me request our Finance Secretary, Dr. Naren Sehgal. Thank you, sir, for joining. There's a wedding in your family this Sunday. Thank you for joining. And please hand over the certificate of appreciation to both Dr. Rahul and Dr. Jesu.
Sure, ma'am. I think it was a fantastic topic and presented very, very well. As a head of an institution, even I got a lot of insights into, how change should be brought in, because that is the need of the hour. And I would like to thank you, Dr. Rahul and Jesu,
Thank you, sir.
and would like to hand over this certificate to you from CAHO.
Thank you.
Thank you.
Thank
So
you.
much. Thanks, dear friends. Let me take quickly 5 minutes to brief you about the upcoming activities this week and the following month. Preeta, can you please screen share? Yes, the next speaker for this International Webinar 64 is Professor Amar Shah from, again, Zulekha Healthcare National Clinical Director for Quality Improvement, England. And, he's going to be an excellent speaker recommended by ISQua. And he's going to be speaking on managing quality and going beyond quality improvement, QI. So please block the date and time and be with us evening 5 p.m. Indian Standard Time. This month, we wish to thank all our Centers for Quality Promotion from across the country for joining this webinar from their boardrooms and their conference rooms. And we really appreciate you for taking your time and for sharing the knowledge with small and medium hospitals and your own staff from across the region. Thank you, all of you, for joining us today. And these are some of the flyers that have been circulating across the country the past 2 weeks. Some of the other upcoming activities we have: training programs, quality implementation, our basic program, our flagship program. It's on the 7th March 2026, 2-day program. It's a virtual one. Master class on IK standards. So this is on the ECO standards. And this is going to be 10 sessions addressing each of the chapters of the IK standards of NABH. And this is going to start on the 7th March 2026. So this is by our own clinical team, ophthalmologists of CAHO, who are going to be running this. The clinical audit training program for us, 10th February. I'm sorry, this is already completed. I don't know why this has come in. Can you move on, please? Keep moving. Yeah. So the executive program on healthcare management by CAHO and the Indian Institute of Management, Shillong. We will be starting the immersion program on the 4th of May at Shillong. So this is this is going to be a 10-month training program, online mostly, but there'll be 2 cohorts, at Shillong, one in the beginning and one towards the end. So the dates are announced 4th to 8th May. And this is a very exciting program. And we've had wonderful participants from all over the globe and country joining us. And this year, we are really looking forward to having many of you joining this program. So if you want more details, you could contact any of the CAHO Secretariat member, or also, you could join us at our website, look at it in our website for more information.